I'm Kerry Cho. I'm one of the nephrologists here. It's good to see Jade. So I want to make this really informal. If you have any questions, just feel free to interrupt me. Hopefully I can help you guys with any kind of questions that you've always wanted to ask a nephrologist. I have no disclosures, and here's our agenda. So we're going to talk about the dialysis circuit, some terminology like blood flow rates, access pressures, access flow rates, the whole purpose of monitoring versus surveillance, and then hopefully leave some time for questions and discussion. So, what is the purpose of monitoring vascular access for hemodialysis? Well, ideally, we would have optimum dialysis. Patients would feel well, they would have excellent vitals, blood pressure, volume status, their labs would be spot on, and they would get dialysis on a predictable schedule with minimal disruption and chaos. And what I tell dialysis patients when they start dialysis is, be prepared for some chaos. If your access clots, your plan for dialysis that day is out the window. Your plans for lunch or dinner with your friends is out the window, and you might end up in the IR suite or in the emergency room, right? Dialysis life can be very chaotic and very unpredictable. What are we trying to avoid? Vascular access clotting, obviously requiring urgent services from you guys. Weekend and after hours procedures, dialysis patients don't like that any more than you guys don't like that. We don't want to do too much surveillance, and we don't want to do preemptive procedures on access that don't necessarily benefit the patient, okay? And obviously we want to avoid trips to the emergency room over weekend hospitalizations because IR is not available, and we obviously want to avoid temporary and tunnel dialysis catheters. Okay, so this is a dialysis circuit for a non-nephrology crowd, very simple. You have your access in the lower right, and this is all driven by a blood pump. Okay, the peristaltic pump is in the lower left, and that generates a negative pressure on this side. And the post pump, it generates a positive pressure. So the negative pressure pulls the blood out of the access, and the positive pressure pushes the blood through the circuit. It's kind of like squeezing toothpaste from the bottom of the tube. Okay. And along the way, you see a couple areas where we measure these pressures. There's the arterial pressure, and then there's the venous pressure. Okay. And the speed of the blood through the circuit is determined by the rate at which the blood pump is pumping. Okay. And the typical flow rate for a catheter is 300, 350, maybe 400 mils per minute. And then for fistulas and grafts, you're really looking for 400 to 450. Okay. Because the rate limiting step in dialysis is the access flow rate, right? How fast can you keep the blood going through the circuit? Well, what can influence this? What causes decreased blood flow rates through the circuit? Now, keep in mind that there can be cannulation issues and there can be patient factors, which are separate from actual problems in the fistula or graft itself. Okay, if you're using needles that are too small, that will limit your flow rates. Okay, now that's not usually a persistent problem because the nephrologist will adjust the needle size and go from 17 gauge to 16 gauge and down to even 15 or 14 gauge needles to allow the maximal flow rate. Poor cannulation technique, you might have a bad session or a couple sessions because of an inexperienced dialysis tech, or just a bad example of cannulation by a very experienced tech. Like sometimes things just go wrong, okay? But again, that shouldn't be a permanent, persistent problem, and that's not necessarily directly related to the graft or fistula itself, okay? If your cannulation results in infiltration and a hematoma, that can also cause extrinsic compression of the fistular graft. But again, that usually only lasts for a few days, a few treatments, and it resolves typically over a couple weeks, okay? And then in terms of patient factors, patient moving their arms, restrictive clothing, all this stuff can cause issues with the access flow or the blood flow, but it's not necessarily an issue with the access itself per se, okay? So we really shouldn't be calling you guys just because of decreased flow rates through the circuit, unless it's really associated with other features. If the patient's not doing well clinically, like uremia, azotemia, or lab findings that indicate that there's actually an underlying issue with the access itself, okay? So what do nephrologists worry about? Okay. Well, these are the things that we will call you guys about. This was what triggers us to call you guys, okay? I love this coffee mug. I thought it was unique to nephrology, but you can actually go online and get the same mug for interventional radiologists too. It's not just unique to nephrology. Okay, but this is a list of why we will call you. Okay, persistent problems with cannulation, even when you have the best sticker in the building, cannulating the fistula graft, we will potentially call you or get an ultrasound. Okay, prolonged post-dialysis bleeding, that could be an issue with downflow, outflow issues with the graft or fistula, okay, because that increases graft pressures and causes bleeding from the sites, okay? Then a host of dialysis-related issues, azotemia, uremia, hyperkalemia, acidemia, the typical indications for dialysis. If you see these things in a maintenance dialysis patient, something is potentially wrong with your access. And then at the bottom, just bad dialysis, what nephrologists call poor clearance, poor kinetics, poor dialysis adequacy. We might throw this term KT/V or urea reduction ratio at you as kind of objective measure that there's something going wrong with the dialysis. Okay, so we have ways of quantifying the dose of dialysis that we're providing, and so you might hear us drop these words, the KT/V is low or the URR is low.
What is high circulation?
Oh, we'll get there. Yeah, we'll get there. So peristaltic pump, you're monitoring the pressures at different areas in the circuit, and by convention, we call this arterial and venous pressures. But that's kind of a misnomer because obviously we're measuring these same pressures when you're using a dialysis catheter, and that catheter is obviously venous, right? But by convention, where the blood comes from is arterial, and where the blood goes back into the patient is venous, okay? It'd be better to call it source and return, okay? But that's by convention. So arterial is pre-pump, it's always negative, and venous is always post-pump, it's always positive, okay? How do we use these pressures? Well, high access pressures might be a sign of a problem intrinsic to the graft or fistula itself. Now, when we say high access pressures, what we really mean is very negative arterial pressures or very positive venous pressures, but we usually just say high access pressures, okay? And a very negative arterial pressure might be a sign of an inflow issue, like an anastomosis issue, or collateral veins that are preventing one large vein from developing properly for the outflow, okay? And then a very positive venous pressure can be a sign of stenosis downstream, okay? So keep in mind, like I mentioned, a lot of these things can be transient, right? It might be just unique to that one treatment. It is not actually a reflection of the graft or fistula itself.